Peter, if the scan had only shown some isolated para-aortic nodes, no liver mets, I mean, more and more people with colon cancer, you would remove the nodes, and even if there was one liver met, you remove the liver met, and you get some quite good results.
Yes.
What's the case for surgery here if it wasn't quite so as extensive as is in Jane?
I think the case for surgery, if you had isolated para-aortic nodes that had not previously been irradiated, and investigation such as a PET scan had shown no evidence of disease elsewhere, then you might consider perhaps removing the enlarged nodes and then asking Chris to follow on with some para-aortic radiation as a means of controlling. But no one can give you data about how well that's going to work in a big group of people. It's a very unusual scenario.
I mean, there's level 3 evidence that surgery for recurrent para-aortic nodes and post-op para-aortic strip radiotherapy is associated with about a 25% 5-year survival, and that's pretty impressive if you think about the situation. Yeah. And so we do make that recommendation.
But it's not great evidence
when we see that situation.
So, Katie, nobody's been talking about palliative care referral yet for this. I mean, we're into a palliative care situation, aren't we?
Well, I think we are, but I would question again: are we in a little p palliative situation? And certainly, this woman is going to die.
But isn't that the key question? If you know somebody's going to die, that's the time for a. It doesn't matter when.
So this woman's being very well looked after by a team, including a very good general practitioner.
Well, this is the general practitioner in this case, yes, the country GP.
So I would be asking the team, how can we value add? Now, physically, she's travelling reasonably well, but how is she travelling with other symptoms? Remembering that palliative care is not just about physical symptoms. How is she travelling psychologically, emotionally, spiritually? How could specialist palliative care value add to that? Or is she at the moment being well managed by a team of people who know her, always with the knowledge that if the complexity of symptoms start to exceed what the team can manage, acknowledging this is a comprehensive team based not only in the hospital but outside of the hospital. If she has questions that she'd like a second opinion, so she said to Chris, "Am I dying?" And Chris said, "Yes, you are." If she wanted to explore that in more depth with someone who's prepared to sit down and talk to her, to ask her openly what she'd like to talk about the dying process, then I think palliative care, specialist palliative care, would be an enormously useful intervention. But at the moment, if the team feels she's travelling well within her current supports, with the knowledge that specialist palliative care is available as soon as possible, should she need it, then I would be reasonably comfortable.